countywide resource management and the managed care division. And the thought behind that is that what we want to do is the managed care division oversees inpatient hospitals and does utilization review for inpatient hospitals and countywide resource management. Are you all familiar with countywide resource management? So countywide resource management, what we've done historically is we place patients that are on LPS conservatorships and other patients into different levels of care depending on their acuity. So we receive packets from different sources of referrals, whether it's inpatient hospitals or jails or state hospitals. We assess those packets and then we make referrals to place those patients into different levels of care. And I'll go over those different levels of care. So if the patient is conserved or if the patient is not conserved, we'll look at the symptoms that that person has and we'll make a recommendation as to what level of care that person should be in. And the thought was that if we merge the group that has oversight of inpatient hospitals and the group that has oversight of the levels of care after inpatient hospitals, if you look at them from on a spectrum from inpatient hospitals to subacute level of care to ERS level of care to crisis residential treatment programs, urgent cares, and everything after that, you would have fewer gaps in the system, right? So, because frequently what happens is we have people who fall through between inpatient level of care and subacute or inpatient level of care and crisis residential or other levels of care. So that was the thought behind that. We want to decrease people that are falling through the cracks. So we've started to merge the two systems with the thought that we can capture more people and get better flow through the system so that we don't have people waiting on the wait list. So some of you may have your loved ones who've been waiting to get into what we call an institution for mental disease for several months. Sometimes the wait list will be 5 months or 6 months or sometimes longer than that. And we wanted to increase flow through the system so that people aren't waiting as long. So let's talk a little bit about what the different levels of care are. So if you've had different persons or different loved ones, many of you are familiar with inpatient psychiatry. So that's our first level of care, is inpatient psychiatry, and that's overseen by the Department of Healthcare Services, and we would provide concurrent review for inpatient psychiatry level of care for fee-for-service hospitals. And we also have what we call care reviewers or clinical care reviewers that are placed at Department of Health Services. So what they do is they'll see the patients that are there, they'll make an assessment, they'll make a recommendation as to what level of care the patient should be on and help move the patient from, let's say, inpatient level of care to subacute. How many of you are familiar with what subacute level of care is?
What is the word?
Subacute?
Subacute.
Subacute? Okay.
That's the crisis stabilization.
So
That's where
that's-
my daughter.
Okay,
from
so,
the acute to crisis stabilization urgent care.
okay, so that's close. So inpatient level of care is acute inpatient. And from acute inpatient, if the patient is placed on a conservatorship, they may be recommended to go to what we're now calling subacute level of care, or an IMD. So an IMD comes in two flavors. There's a SNF specialty treatment program, and there's a mental health rehabilitation center. And they're essentially, for all intents and purposes, the same. The differences are statutory. They're written in code. The differences are the amount of nursing care and the amount of hours per group, or groups per week. But if your loved one is recommended to go, is on a conservatorship, needs to go to a locked level of care, and is no longer, is now stabilized from acute inpatient psychiatry and can go to the next level of care and still needs locked treatment, they're probably going to be recommended to go to subacute level of care. And that would be either a SNF special treatment program or a mental health rehabilitation center.
Which is generally what we've all been saying is IMD, just so you guys, from what you've seen in the last two presentations, the IMD is kind of subacute now, the new terminology. Skilled nursing facility.
Oh, okay.
Okay? So the next level of care, if your loved one sort of graduates from a locked level of care or doesn't need a locked level of care, they can go to an open level of care. And open means that the doors are open during the day, they can kind of come and go as they please. They probably need fewer hours of group per week, but they still are needing some level of treatment programming, still probably needing some level of medical care during the week. Maybe the medications need to still be dispensed to them. Our next level of care is enriched residential services. And at those programs, what they have, enriched residential services. And I can make a handout and provide that to Gail. I don't know where she is, right there. And have this for you in a cheat sheet, if that would be helpful.
Yes.
And enriched residential services, what we have are slots for our clients, and they're at a board and care level and have additional treatment planning during the week. So medications are dispensed, the psychiatrist comes, and there's group therapy during the week.
Is this the same thing as ERH?
ERS.
Yeah, it should be ERS. It was on your paperwork as ERH, but it's ERS.
Okay, thank
Yeah.
you.
Other levels of care in our network that someone just mentioned was an urgent care. So an urgent care, or something that's sometimes licensed as a crisis stabilization unit, is it's sort of like a psychiatric emergency department, but the difference between an urgent care and the psychiatric emergency department is at the psychiatric emergency department, there's no limit to how long the patient can be there. At the urgent care, typically the patient can be there 23 hours. That's the guideline, basically by statute. And if they need to be there longer than 23 hours, they're typically transferred to a psychiatric emergency department. That's typically how it works. So we have a couple of psychiatric urgent cares in our system, and we use those as well for patients or for clients that are
in front of security office.
in a psychiatric crisis.
In front of security office.
They're
in front of security office.
They're what we call crisis residential treatment programs. So there's an urgent care and there's a crisis residential treatment program. The crisis residential treatment program is like a crisis home where they can stay for up to 4 weeks at a time. So that's a short-term residential treatment program.
How do you get in that program?
So these are all programs that they're referred to, let's say the inpatient psychiatrist refers them to intensive care division. We screen the referral.
From the hospital?
From the hospital or from the urgent care, and then we refer them to the CRTP.
And
So
that
the
has
social
housing.
worker, the crisis residential treatment has housing?
It's a house,
Okay.
and it has beds and programming and dispenses medication, that type of thing. I'm sorry?
So is that the psychiatrist or the social worker in the hospital that refers the
Correct.
patient?
Yeah, and there's paperwork. They have a couple of different forms that they need to fill out.
Yes, it is.
I'm
You
sorry?
just said it's complicated.
It's a large network of different levels of care that we oversee, but kind of once you kind of get to know the system, it's a little less complicated. And I apologize, I didn't bring something with you so that I could show it to you, but I can put it on a map for you, and I think it'd be a little bit simpler.
Or you can even make it simple, just call her.
Or you can call. And if you need something, give me a call. So let me give you my phone number. Let me start there. 213-738-4775. And that's the general number to the intensive care division. If I'm not there for any
Sorry,
reason,
can you say it again? I'm sorry, we haven't been.
213-738-4775.
And what's your name?
Dr. Ruiz, R-U-I-Z.
Oh, Ruiz.
My first name's
Code assist,
Amanda.
all clear. Code assist, all
Amanda.
clear. Code assist, all
One of the
clear.
reasons we would call you.
So, that's a good question. So typically, the most common reasons I get called, or I have a colleague that works with me, so if you can't find me, you can find Linda. Your loved one has been hospitalized and you're having trouble talking to the treatment team. We get that one all the time. You're having trouble contacting someone to get assistance with getting your loved one the assistance that you need, and we can help you with that typically. Help me out, Gail, what are other questions that